I'm Benjamin Hayes, lead trauma nurse in the Level 1 Trauma Center at Grady Memorial Hospital in Atlanta, Georgia. That was my identity, my purpose, my entire professional life, until everything I understood about medicine shattered on one impossible night last month, forcing me to walk away. I hold advanced certifications in emergency nursing, trauma nursing, core course instruction, and advanced cardiovascular life support. I've trained incoming nurses, mentored residents, and received 3 commendations for excellence in patient care under extreme circumstances. I've seen everything you can imagine in trauma medicine. Gunshot wounds that should have been fatal. Car accidents where we piece people back together with titanium and determination. Industrial accidents that redefined what the human body could survive. I've held pressure on spurting arteries while surgeons scrubbed in. I've watched hearts restart after being still for minutes. I've pronounced deaths and witnessed miraculous recoveries that defied every statistical model we had. But what I'm about to tell you is the one case that made me question everything I thought I knew about human physiology and ultimately led me to leave the profession entirely. Grady Memorial is a massive complex spanning several city blocks in downtown Atlanta. Our trauma center handles over 5,000 critical cases annually. The facility operates with military precision, 3 fully equipped trauma bays, dedicated CT and MRI suites, direct elevator access to 8 operating rooms, and a helipad that sees constant traffic. The emergency department buzzes 24 hours a day with the controlled chaos that becomes comfortable after your first few years. The fluorescent lights never dim, the monitors never stop beeping. The overhead pages never cease calling doctors to various codes and consults. I worked the 3 to midnight shift, the sweet spot where day trauma bleeds into night violence. My team consisted of 5 nurses, 3 residents rotating from Emory University School of Medicine, and 4 attending physicians who'd seen more carnage than most war surgeons. We were good. We were fast. We saved lives other hospitals would have lost. That's why what happened on September 14th still haunts me. That's why I can't close my eyes without seeing her face. That's why I finally walked away from the only career I'd ever wanted. The evening started routinely enough. A motorcyclist with road rash and a fractured clavicle in Bay 1. A construction worker with a nail gun injury to his thigh in Bay 2. An elderly woman with a fall and possible hip fracture waiting for orthopedics. Standard Thursday night in Atlanta. I was reviewing labs with Dr. Madison Carter, one of our senior attendings, when the radio crackled. Grady Trauma, this is Medic 12. We're inbound with a Priority 1, ETA 6 minutes. Female, approximately 25 years old, ejected from vehicle in high-speed MVM on I-85. GCS of 4 at scene, now 6. Multiple traumas, suspected internal bleeding. BP 70/40 and dropping. We've got 2 large-bore IVs running wide open. I acknowledged the call and activated our trauma protocol. Within 90 seconds, Bay 3 was prepped. Respiratory therapy stood by with intubation equipment. Lab runners waited for blood samples. The massive transfusion protocol was on standby. Dr. Carter scrubbed while I positioned our team, each person knowing their role without needing instruction. The ambulance bay doors burst open at exactly 8:15 p.m. The paramedics wheeled her in fast, their faces showing that particular strain that comes from working a patient who's circling the drain. She was young, maybe mid-20s, with long dark hair matted with blood and glass. Her clothes had been cut away, revealing extensive road rash down her left side, and an abdomen that was already distending with what could only be massive internal hemorrhage. "On my count," I called out. 1, 2, 3. We transferred her to our trauma bed in one smooth motion. I immediately began my primary assessment while calling out findings. Airway compromised, breathing shallow at 32 per minute, radial pulse thready and weak. The monitors lit up with numbers that made my stomach drop. Heart rate 140, blood pressure 68/35, oxygen saturation 89% and falling despite high-flow oxygen. "She's crashing," Dr. Carter said unnecessarily. "Get me a crick kit and prep for emergency intubation." But that's when I noticed something odd. Despite her critical vital signs, despite the obvious trauma and blood loss, The patient's eyes were open, not the glazed, unfocused stare of someone in shock. She was looking directly at me with clear, cognizant brown eyes that tracked my movements with perfect precision. Patient appears alert, I noted, my training overriding my confusion. GCS reassessment needed. Dr. Carter leaned over the patient. Can you hear me? What's your name? The woman's lips moved. Her voice was barely a whisper, but perfectly clear. Sophia. Sophia, you've been in a bad accident, Dr. Carter continued, already moving to secure her airway. We're going to help you. I know, Sophia said, and smiled. That smile. I've replayed it 1,000 times in my mind. It wasn't the delusional happiness of someone in shock. It wasn't the grimace people make when they're fighting pain. It was calm, knowing, almost amused. Her blood pressure dropped to 60/30. She's going to code, Tyler Grant, one of our senior nurses, called out. We need to move now. Dr. Carter attempted intubation, but Sophia turned her head and spoke again. Her voice somehow stronger despite the monitor showing her pressure continuing to fall. That won't be necessary. Ma'am, you need to stay still, I said, holding her shoulder. Her skin was cool and clammy, exactly what you'd expect from someone bleeding out internally. But her eyes remained perfectly focused. The ultrasound probe revealed what we suspected. Massive free fluid in her abdomen. Blood. Litters of it. Her spleen had clearly ruptured. Possibly her liver as well. The trauma surgeon, Dr. Lucas Parker, arrived and took one look at the screen. She needs to be in the OR 5 minutes ago, he said. This is a critical bleed. Sophia's blood pressure read 55/28. At that pressure, most patients are unconscious or nearly so. The brain simply doesn't perfuse adequately. Yet Sophia looked at each of us in turn, her gaze sharp and assessing. You should check my labs, she said clearly. It was such a bizarre statement that we all paused for a fraction of a second. Patients in hemorrhagic shock don't make clinical suggestions. They don't speak in full sentences. They certainly don't remain alert and oriented while their MAP drops below 60. Run a complete panel, Dr. Carter ordered, but she was already frowning, noticing the same impossibility I was seeing. We pushed 4 units of O negative while preparing her for emergency surgery. Her pressure should have responded even slightly. It didn't. 50/25. Then 48/22. She was dying in front of us, but she wouldn't stop talking. The accident wasn't random, she said as we rushed her toward the OR elevator. I need you to understand that. None of this is random. Save your strength, I told her, though the words felt absurd. She shouldn't have any strength. She should be unconscious. The lab results came back as we prepped for surgery. I was drawing up medications when Tyler handed me the printout, his face pale. Ben, you need to see this. Her hemoglobin was 12.8. Normal range for a woman is 12 to 16. She had the hemoglobin level of someone who hadn't lost any blood at all. That's wrong, I said immediately. Run it again. She's obviously hemorrhaging. I told them that, Tyler said. They ran it twice. Same result both times. Her lactate, which should have been elevated in shock, was 1.2. Normal. Her pH was 7.40. Perfect. Every marker of hemorrhagic shock was absent, despite the ultrasound clearly showing liters of free blood in her belly and vital signs indicating imminent death. Dr. Parker scrubbed in while Dr. Carter and I exchanged looks that conveyed our shared confusion. Anesthesiology was preparing to put her under when Sophia spoke one more time. You're going to open me up and find nothing wrong, she said, and that's when you'll start to understand. The anesthesiologist, Dr. Ava Mitchell, administered the induction agents, propofol, fentanyl, rocuronium, doses calculated for her estimated weight. She should have been unconscious in seconds. Sophia's eyes stayed open. That's unusual, Dr. Mitchell said, checking her IV line. She should be out. She pushed another dose, then another. Enough propofol to sedate someone twice Sophia's size. The monitors showed her blood pressure still dropping, now 40/18. Her heart rate climbing to 160, but her eyes tracked all of us, unblinking. I can't put her under, Dr. Mitchell said, her voice rising. She's not responding to anything. Then we go without, Dr. Parker said grimly. She's going to die if we wait. General anesthesia is preferable, but we don't have time. They prepped her abdomen with betadine and made the initial incision. I stood by with suction and additional blood products. Dr. Parker cut quickly but carefully through skin, subcutaneous fat, fascia. Sophia didn't flinch, didn't react at all. The monitors showed a blood pressure incompatible with consciousness, and she'd been given enough sedation to drop an elephant. Yet her eyes watched the surgeon cut into her abdomen with that same calm, knowing expression. Dr. Parker entered the peritoneal cavity and paused. I leaned in with suction, ready for the expected rush of blood. There was nothing. "Where's the blood?" Dr. Parker asked, his gloved hands exploring her abdomen. The ultrasound showed massive hemoperitoneum. He checked her spleen, intact. Her liver, perfect. Her kidneys, bowel, major vessels. Everything was anatomically normal and completely uninjured. "This isn't possible," Dr. Carter said from beside me. We all saw the ultrasound. There were liters of free fluid. "There's no trauma here at all," Dr. Parker said, his voice strained. "No lacerations, no bleeding, not even any bruising." I looked at the monitors. Blood pressure 42/15, heart rate 170. She was dying according to every instrument we had, but Sophia's abdomen was completely normal. "Close her up," Dr. Parker finally said. "I don't know what to tell you, but there's nothing to fix." They sutured her closed while I stood there, my entire understanding of trauma medicine crumbling. The ultrasound doesn't lie. Free fluid in the abdomen after trauma is blood. Always. We'd all seen it. Dr. Carter had performed the scan herself. We brought Sophia back to the trauma bay, where the impossible continued. Her vital signs showed progressive shock. Her labs showed perfect health. Her surgical findings showed no injury. And through it all, she remained conscious, watching us with those knowing eyes, despite enough sedation in her system to have stopped her breathing entirely. "Someone repeat the ultrasound," Dr. Carter ordered. Tyler performed the scan. We all crowded around the screen. The abdomen was clear. No free fluid, no blood, nothing. "It was there," Dr. Carter said. "I know what I saw." "We all saw it," I agreed. Sophia spoke from the bed, her voice cutting through our confusion. "You saw what I needed you to see." The room went silent. Her blood pressure on the monitor read 38/12. At that pressure, she should have been dead, certainly unconscious. The brain cannot function without adequate perfusion. It's physiology. It's absolute. "What are you?" Dr. Mitchell whispered. Sophia's smile widened slightly. "Someone who needed to show you that everything you think you understand has limits, that your instruments and your training and your certainty can only take you so far." Her heart rate climbed to 190. Her pressure dropped to 35/10. "She's going to arrest," Tyler said, reaching for the crash cart. "No," Sophia said. "I'm not." And she didn't. For 3 more hours, she maintained vital signs incompatible with life. We tried everything. More fluids, pressors. Nothing changed her numbers, but she remained alert and conversational. We drew labs every 30 minutes. Each time, they returned normal. We repeated imaging, always clear. At 11:40 p.m., her pressure suddenly normalized. 110/70. Heart rate dropped to 75. Everything corrected in the span of a single minute. "I can go home now," Sophia said, sitting up. "Absolutely not," Dr. Carter said. "You're not going anywhere until we figure out what's happening." "You won't figure it out," Sophia replied, disconnecting her own IV with steady hands. "Because it's beyond your figuring." Security was called, but by the time they arrived, Sophia had walked out of the trauma bay in a pair of scrubs someone had left on a chair. We reviewed security footage later. She left through the main entrance at 11:55 p.m., walking normally, showing no signs of trauma or distress. We filed reports. We held a department meeting. Everyone who'd been in that room confirmed the same impossible details. The ultrasound showing massive hemorrhage, the vital signs incompatible with consciousness, the normal labs, the negative surgical findings, the resistance to anesthesia, the sudden normalization. Dr. Mitchell reviewed her anesthesia records 3 times. "I gave her enough propofol to sedate her for 8 hours, she told me the next day. "Where did it go? How did she metabolize it instantaneously?" We sent her labs to the reference lab at Emory for confirmation. The results came back unchanged. Normal hemoglobin, normal lactate, normal everything, drawn while she was actively dying according to our monitors. Calibration error, administration suggested when we presented the case in M&M conference. The monitors must have been wrong. All of them, I asked. The automated blood pressure cuff, the arterial line we placed, the pulse oximetry, the cardiac monitor, all simultaneously wrong in the exact same way? No one had an answer for that. I tried to find Sophia. The ambulance had no record of her real identity. The car she'd been ejected from was registered to someone who'd reported it stolen 3 days earlier. The address she'd given paramedics didn't exist. Sophia was a ghost in our system, a patient who shouldn't have been possible. That would have been enough to shake me, but it wasn't the end. 3 weeks later, a man came in after a fall from a construction site. 4th floor, landed on concrete, multiple witnesses. Jason Miller was his name according to his ID. Massive head trauma, skull fracture visible on CT scan, brain bleed, ICP elevated. Everything indicated severe traumatic brain injury. But Jason was alert, oriented, and asking for coffee. His CT showed the injury. His neurological exam showed perfect function. The neurosurgeon, Dr. Ethan Brooks, stood looking at the scans and then at the patient. His expression troubled. "This doesn't make sense," he said quietly to me. "With this injury, he should be obtunded at best, more likely comatose." "I know," I said, because I did. I'd seen this before. Jason was admitted for observation. 6 hours later, a repeat CT showed complete resolution of the bleed and healing of the skull fracture. 6 hours. Injuries that should take weeks or months, if they healed at all. "You'll want to study this," Jason told Dr. Brooks, "but you won't find answers. Some things are beyond your instruments." The same words. Almost exactly. He checked himself out against medical advice the next morning. A month after that, a woman came in with 3rd-degree burns over 40% of her body from a house fire. Olivia Reed. She should have been screaming in agony. Instead, she lay quietly on the gurney, her burned flesh visible and documented by our burn team. "I'll be fine," she told me. "I just needed you to see." Her burns healed completely overnight. Completely. No scarring, no grafting needed. The burn team photographed every stage, documenting something that contradicted everything we knew about wound healing and tissue regeneration. The pattern was undeniable now. Patients presenting with injuries that should have been critical or fatal. Vital signs or scans confirming the severity. Perfect consciousness and awareness despite conditions that should have precluded it. Then rapid, impossible recovery. Always with that same knowing look. Always with words suggesting this was intentional, demonstrative. I brought my concerns to Dr. Carter. She'd seen all 3 cases, witnessed the impossibilities firsthand. "What are you suggesting?" she asked me. "That these are what, not human? That's insane, Ben." "Is it more insane than someone being alert and oriented with a map of 40? I countered. "More impossible than burns healing overnight? Than brain bleeds resolving in hours?" She didn't have an answer. I started doubting everything. Every patient who came through our doors, I wondered if they were real, if their injuries were real, if any of what we were seeing and treating matched reality. Trauma nursing requires absolute confidence in your assessment skills. You have to trust your eyes, your hands, your instruments. You have to believe that when you see something, it's real, and when you measure something, the numbers are true. I couldn't believe that anymore. A motorcyclist comes in with a compound fracture, and I'm wondering if the bone is really broken or if I'm seeing an illusion. A gunshot victim bleeds on my trauma bay floor, and I'm questioning whether the blood is real. Every vital sign becomes suspect. Every lab result potentially false. I couldn't function like that. I couldn't do my job while questioning the fundamental nature of reality every time a patient rolled through those doors. The breaking point came on a routine shift in November. A simple case, an elderly man with chest pain. Straightforward, except I spent so long second-guessing the EKG readings, wondering if his heart was really in distress or if this was another impossible patient, that I delayed treatment by crucial minutes. He survived, but my hesitation could have killed him. That's when I knew I was done. I submitted my resignation on November 18th. Dr. Carter tried to talk me out of it. Administration suggested a sabbatical, counseling, but how do you counsel someone back to believing in objective reality? How do you take a sabbatical from questions that have no answers? My last shift was December 1st. I trained my replacement on the protocols, the equipment, the rhythm of trauma care. I didn't tell her what I'd seen. What would be the point? Either she'd think I was insane, or she'd see it herself eventually. On my way out that final night, I walked through the trauma bay one last time. The monitors beeped their steady rhythms. The overhead lights hummed. Everything looked solid and real and trustworthy. But I knew better now. I knew that sometimes patients come through those doors, carrying impossibilities. That sometimes what we see and measure and document defies every law of biology and physics we've built our profession upon. That sometimes people walk among us who can show us the limits of our understanding with a smile and a knowing look and injuries that shouldn't exist. I think about the patients I'll never see now, the lives I won't be there to save. But I also think about Sophia and Jason and Olivia and wonder how many others there were that I didn't recognize. How many impossible patients passed through our trauma center over my 12 years, hiding their true nature. Their injuries healing in ways we attributed to luck or resilience, or the remarkable capacity of the human body. How many times did I look at someone and see only what they wanted me to see? I don't have answers. I don't think I'm meant to have answers. Some doors once opened can't be closed. Some knowledge once gained can't be unknown. I'm not a trauma nurse anymore. I'm just someone who learned that the world is stranger and more uncertain than any textbook ever suggested, and that sometimes the most terrifying thing isn't what you see in a trauma bay at 3 a.m., but what you realize you've been seeing all along without knowing it. The instruments don't lie, we always said. The numbers don't deceive, but what if they do? What if they only show us what we're capable of understanding? And the real truth lies somewhere beyond the reach of our monitors and our labs and our absolute certainty. I don't know what Sophia and the others were. I don't know why they came to Grady Memorial. I don't know if they're still out there, walking into emergency departments across the country, showing other nurses and doctors the same impossible truths. But I know I'll never look at vital signs the same way again. And I know that somewhere in Atlanta, there's a woman with knowing brown eyes who's perfectly aware that she broke something fundamental in me that September night. Something that, unlike her impossible injuries, will never heal.